Hi, I'm Lesley Curtis, a chair and professor of population health sciences at Duke University and a deputy editor at JACC. Today, I'm joined by Dr. Celina Yong and Dr. Rob Califf to talk about their new viewpoint, A Quarter Century of ACS Guidelines, Gaps Within Evidence Gaps, which appears in JACC's first ever dedicated issue on clinical practice guidelines. Dr. Yong is an associate professor of medicine at Stanford and director of interventional cardiology at the Palo Alto VA. She leads a robust health services research program and is actively involved in many trials of novel therapies for cardiovascular disease. And she's also an associate editor at JACC. Dr. Califf served as FDA commissioner in both the Obama and Biden administrations and is now back home at Duke, where he previously led the DCRI and served as vice chancellor for clinical and translational research. He's long been a national leader in improving the evidence generation ecosystem. It's great to have you both here today, and welcome.
Thanks.
So your piece opens with a really striking data point that out of about 100 new ACS recommendations, more than a quarter are now based on high quality evidence, which is a big step forward compared to prior years. Do you think we're finally turning a corner, or do you suspect that the progress is more fragile than it might appear?
Well, I'll start out and just say I think I'll be the cup half empty guy, which is a role I frequently play. And I think it's extraordinarily fragile, especially in this day and time when there's so much pressure on clinicians to generate revenue and not spend time with the hard work it takes to do adequate, well-controlled, randomized trials by getting consent from patients that they're seeing to answer these critical questions.
Well, on the counter to that, if you look at the last set of guidelines that were about in the 8% range for level of evidence A, we have come a long way. And certainly even looking back, a quarter century ago when the first set of ACS guidelines came out that Dr. Califf was a part of, it's amazing to see how far we've come. But I think, to your point, when about 3/4 of the guidelines still don't have level of evidence A, we have to wonder where are those gaps. And certainly there are many that are even laid out in the guidelines themselves. But one of the things that we were looking at were not just what the topics are, but a couple other dimensions of where sort of the gaps within the gaps might be. And some of those factors relate to the degree of alignment with commercial interest and how much the data that we have are applicable to the actual patients in front of us. And certainly, even when we know they apply, practically speaking, how do we implement them? And how much of the efficacy is related to the way they're actually implemented? One example I can go into is the danger shock trial. There has a new recommendation now, but recently in JACC we published a manuscript looking at the application of danger shock criteria in a real world population in Michigan, and it showed such heterogeneity in the application of the microaxial flow pump, and it raises so many questions, unanswered, gaps within those gaps.
Yeah, that's great, and I appreciate you bringing up that example, Dr. Yong. I thought really one of the most compelling arguments in your piece is just that we often don't know whether evidence is truly applicable to the broad populations in which the evidence is applied. Can you say a little bit more, explain why the distinction really matters, and what are the risks when we overlook that we're missing that piece?
We've seen in so many studies now that when we look at differences by age, gender, genetic polymorphism, social needs, geography, the efficacy of a tool or drug or treatment approach can vary. And when we include those groups, we start to see some of these findings that we sometimes don't see in the initial studies. We gave an example of clopidogrel, and certainly seeing the variable efficacy in different groups has helped us gain a better understanding of how to use it and the need for, now we have even better, antiplatelet meds. But that's just one example. And we're just at the start with so many of these studies that have done such rigorous work, but often don't include the true representative population that we treat. And so much more work has to be done there.
Another point that Celina's made as we discuss this, it was a lot of fun to write this piece because she obviously represents a more enthusiastic younger generation seeing the great future, and I'm the old beat up veteran of all this. But it's not just the population study, it's the institution and the operators in the case of device trials in particular. I will never forget the first randomized trial of atherectomy, the caveat trial, where it we had a meeting just to look at the complications that occurred, and it was like a showpiece of guide wires being tangled up in different directions, et cetera. And so regardless of the procedure, if you only do the trials in the places that do it the best, you get a very different answer perhaps than what you get when the technology is unleashed on the public.
That's such an important point. So, Dr. Califf, you touched on this a little bit, but you make a point in the piece that we lack a lot evidence for questions that clinicians face every single day. Some, I would argue, really basic questions about things like optimal drug combinations, how long treatment should be continued, or head-to-head comparisons of different treatment strategies. Why do you think these critical kind of day-to-day questions are so often left unanswered?
I think it's fundamentally that there is no compelling funding source that pays for these questions being addressed. And let's face it, the medical products industry, it is really hard to show that something is effective at all. 9 out of 10 drugs that get into phase 1 don't make it to market. Most devices go through multiple iterations and failures before they eventually make it out. And so the industry is highly focused on pre-market clinical trials that answer the question, is there at least some indication where the benefits outweigh the risks in some population for some period of time? And that's all the FDA can really demand legally in the statute to then allow a product to be on the market. After that, the FDA can't force people to do these kinds of studies. And the NIH has allocated a very small part of its resources. Maybe that'll change in the near future. And I would say the other big factor, and I've been spending a lot of time on this since leaving the FDA just over 100 days ago, clinical practitioners, as I've already said, are under tremendous pressure now to simply generate revenue. They're almost all employed now, and tremendous pressure to not spend time that it takes to get consent to participate in clinical trials. And yet, I still love the question, Lesley, that one of our colleagues asked at FDA, what's left on the table after FDA approval? The answer is almost everything. It's how does it compare to other treatments? How long should it be given? What's the right dose? What's the value in terms of the economic costs versus the benefits that are gained? Those things are not known at the time when a product comes on the market, but we don't have a system which is cranking out the answers to those questions that would be so important in a health system that's spending $5 trillion a year for the worst outcomes of any high-income country. So Journal of the American College of Cardiology's got some work to do in America, is what I would say.
Okay, well, I'd be remiss if I didn't ask us to wrap up on a positive note, on a forward-looking positive note. What steps do you think need to be taken to begin to close some of these evidence gaps? Who needs to take them? What are the steps that we could begin to move forward with?
The short answer is everyone has to be responsible. We can't rely on just trusting that, commercial interests will drive a lot of these studies. We have to be looking out for sort of the top left box where, there may be, all of the studies that Rob mentioned, but, the ones that may be overlooked if we don't pay attention to them. And even readers of the ultimate guidelines and also the trials themselves need to be paying attention. How much do these really reflect the patients in front of me, and how am I going to implement this? And that will in turn drive the energy and excitement about new studies that are going to focus on these important unanswered questions.
And I'll take the long view since I was there when all this started, which is one of the fun things about writing this piece was that we went back 25 years ago. The original unstable angina guidelines were the second set of guidelines funded by the Agency for Healthcare Research and Quality at the time. And Gene Brownwald was the chair, and colleagues at Duke were coordinating the effort. And at the time, I think we really learned that when you write a clinical practice guideline, you really do identify what are the decision points that are really important to patients and to clinicians. And then you can say, for these decisions that happen over and over, do we actually know what the right answer is? And of course, we know now the answer to that is no. Most of the time we don't. But we have a good sense based on the foundation of evidence and expert judgment. We should be able to use the guidelines to then say, all right, here are the most important questions that are not answered. And Celina and I took a little stab at that in a table we put in the paper, really just to get the discussion started. And I know, Lesley, you've been spearheading an effort at JACC to solicit ideas from clinicians. All too often, clinicians have been left out. The experts decide what the questions are. There's been a really positive movement towards patient-centered outcomes research with PCORI leading the way, but the doctors and nurses and pharmacists seeing people in everyday practice know what the questions are. It would be great if in our new healthcare policy arena, we put some funding into answering these everyday questions that make such a difference.
Great. Well, that's a great way to wrap up this conversation. It's been such fun to talk to both of you. And again, congratulations on a great piece that really does provide a long-term perspective on how the guidelines have changed over time. So thanks so much, and enjoy your day.
Thank you.
Thanks so much, Lesley.